Hello, ladies. I'm here with Heather Rogers of Summit Physical Therapy, and she is going to talk to us today about what a women's health physical therapist does and how she can help you. So, Heather, take it away. Hi. Tell us a little bit about yourself.
Well, I've been a therapist for 17 years. I went to Wichita State here in Wichita, and that was a master's program back then. And then I went through the University of Montana for my doctorate.
Yep.
A few years after that. But I've always practiced here in Wichita. Did home health for a number of years, and then got into pelvic floor, women's health, maybe 7 or 8 years ago.
Mm-hmm.
So,
nice. Yeah. Okay. So here you are.
Here we are.
Here we are. Okay. So what is a women's health physical therapist?
Women's health physical therapist. It's kind of funny. When I go around, talk to people, and just, even my friends, and they say, what do you do? I'm a physical therapist and women's health physical therapist. And they say, what is that? And I explain it a little bit, and their immediate response is, oh, that's a thing.
Yeah.
Absolutely.
I have a pelvic floor.
Right. I know. We'll get into that. But women's health physical therapist, it's a physical therapist who has the training and the knowledge to evaluate, assess, recognize things that go on within our bodies that really encompass anything with being a woman. I mean, at any stage of life. That can be from before babies. Mm-hmm. For example, say you're training for something and you start to notice imbalances and things creep in and you want to get that looked. Absolutely. And then through pregnancy, huge changes.
Yes,
obviously.
Yes.
And delivery. And all the changes that go the body with that, and then the years beyond. There are changes that occur, with hormonal changes, tissue changes throughout the body as we get older and as we age. So really any stage of life, anything that encompasses being a woman, a women's health therapist can really, really assess and help with all of that.
And there is a difference between women that physical therapists that can do internal exams and people that don't. Is this right?
There are, yeah.
Okay.
There are therapists out there, and I don't know if it's just levels of training. Maybe they haven't had that, but I'll have had patients that come to me that have been through therapy before for pelvic floor, women's health, and they will have not had some of the internal treatment. So, I mean, personally, if I hadn't had that training, I know I wouldn't be, comfortable doing it.
Sure.
So that may just be a practice, type of comfort or just level of training that therapist hasn't gone through yet. So, but it's very easy to go get that. I mean, it's great to go get that training.
Okay. So what are some of the issues that you treat?
There's another one where we get the response, really?
Yeah.
But, oh gosh, anything, when I talk to people, it's so funny. They say, well, what do you do exactly? What do you, because you think of a physical therapist and you think head and shoulder, knees and toes, and hips and ankles and all of that. But I don't know, it's kind of funny. I say, I know you can't see my waist, but I say I treat anything basically from here to mid-thigh. No,
this is mid-thigh.
Inside, outside, really anything. There are a number of things that come through the door that we look at and then we assess and we treat. Anything, from the normal low back pain, neck pain, hip pain, things like that. But then we go deeper into pelvic pain, internal pain, that intercourse pain. That shouldn't be painful. When you go to the doctor and you have an exam and it hurts, and the internal pelvic pain for sure. Incontinence, that's usually what people think of, when they think of pelvic therapy. Those of us that have heard of it, that's always a biggie, whether it be bowel or bladder. Incontinence. Tailbone pain, that's a biggie too, that comes along with
a lot of women break their tailbone in labor.
They do. With whether the changes come about during pregnancy or through delivery, or outside the fall that happens too. People too. But with the pregnancy and delivery, that tailbone can can really start to hurt. So that's a big one too. The abdominal separation that occurs, that we all hear about, and that happens to so many of us.
Yes.
That's a big one.
Pelvic organ prolapse too?
Absolutely.
Yep.
Prolapse. Gosh, I'm trying to think. There's a whole host of things that
I always tell my moms in the postpartum group, you shouldn't have the 3 Ps: pain, peen, or prolapse. If you do, you need to go see someone.
Prolapse, absolutely. Those are the biggies, and like I said, those are the things that we most notice as we go through those changes. Whether you think, okay, I'm leaking now, I didn't used to, or wow, that's painful, and it didn't used to be.
So a couple of questions about incontinence, because a lot of people, I think, if you have any amount of incontinence, that's not normal. While it's common, it's not
very
normal.
common, but it's not normal. And I think a lot of women, and through the years, yes, we started to talk about it more, which is great. We need to. But I think through the years, women have had that misconception, or just that blanket answer, whether it be from talking to friends or doctors themselves. Well,
just pee my pants now.
You've had babies, and you've gone through these changes, and these things happen within your body, and that's just kind of how it is. That's not the case. That's not the case. There's something causing that, whether it be imbalances within the system, or there's something causing that, and we can figure that out.
I think that's so fascinating, because there's so many jokes about it too. I just think.
I know. I was just
it's funny, but it's not funny. Who thinks it's funny? But
we just kind of go along with that. I was talking to a patient yesterday. She came in, and she's so fun. She carries my card everywhere, and she shows, people. And when she was talking to a friend who's pregnant, and she said, "Oh, hold that thought. I need to run. I go to the bathroom before I pee my pants." And they were laughing about it. But she said, "Hey, here's," and she just, that's a thing, and but they laugh, and we laugh and we joke about it, and because I think that's kind of what I was always going with it.
Well, and I think too, in like certain niches of well, for me, coming from a fitness point of view, like in the CrossFit world, this is a big thing. Like, did you work out so hard you peed your pants? Did you lift X amount of weight and peed your pants? It's like a badge of honor.
I think I saw a CrossFit video one time that actually kind of touted that.
Yes.
With box jumpsuits. I don't remember what it was, the specific movement of CrossFit, but they were like, I pee my pants when I do this,
So, I think it's a big thing to...
But that's not normal. There's something going on within your system that we can figure it out.
So interesting. Okay, so let me see. So you kind of talked about some of the most common issues. So kind of one of the most blanket statements we hear is every woman should do Kegels. Is this true? Do your Kegels.
I am so glad you asked this.
Yeah.
Okay. I'm going to give you the answer with yes and no. Because, yes, we've heard for years, just Kegel, Kegel, Kegel all day long. And this is, I have this going on. I'm starting to leak. Oh, well, you just need to
sit at the stoplight and do 10 Kegels every time you come to a stoplight.
Right. Anytime you have a moment, just squeeze all day long. No. Wherein that is part of it. But depending on what is going on with your body, if you are coming from a point where you are holding extra tension in that pelvic floor, those muscles down there, they have to hold a certain amount of tension. But with the changes that occur, whether it be with pregnancy or childbirth or what inflammation through the years, surgeries, scar tissues, those muscles can hold too much tension. Well, then when you just start to do Kegels and you start to contract, and squeeze those muscles, Kegel all day long, it doesn't get better. And it actually, it can hurt, it can make it worse. And you don't see results, you don't see progress, and you remain frustrated. I've had patients come into me from other therapists who, maybe haven't had that training, and they just have them on Kegels and they haven't had that progress. They don't see changes. There's muscle tension that's there that's there's too much. So when you say, no, every woman should not do a Kegel, but eventually they should. Once we get that tension worked out and those muscles released and back to a more normal state, better resting tone, then we can start to strengthen. so they can hold that stability.
Can having a hypertonic floor, so a floor that's too tight, have the same symptoms as having a hypotonic floor?
Absolutely.
Okay, which is why you have to get assessed, because you don't know what's happening.
Yeah, just if I'm leaking, you automatically think it's just loose. It's hypotonic, meaning way too low.
Yeah.
No, that's not necessarily the case, because you can have way too much tension in your pelvic floor and have the same symptoms as far as leakage goes, and that urgency and that frequency. Well, I just went a little while ago and I feel like I have to go again. That's not just, too little tension. That can be way too much, and then you're throwing Kegels on top of that, and it's not a good result.
Yeah.
So yeah.
Okay, so diastasis recti.
Yes.
So everything I've read lately says that it doesn't necessarily matter. Well, okay, so we assess it by width and depth. And so some of the stuff that I've been reading lately says the gap matters. Of course the gap matters, but what matters the most is that when you go to activate it, when your brain tells your core it needs to turn on, the fact that it knows to come together, is that the most important part?
That is a big part.
Okay.
Yes, absolutely. Because we can activate certain ways, but it's not the correct way. And you're not going to be gaining on that stability with that core. It absolutely has to activate correctly.
Okay. Can you tell, one thing that people have been coming to me a lot about lately is umbilical hernias.
Okay.
Is an umbilical hernia just another way that intra-abdominal pressure is presenting itself?
Yes.
Yes and no?
Okay. Yes.
Yes and no.
Yes, there's a breach, basically, in that tissue.
Okay.
And when we go through movements and we go through different, say you're carrying something heavier, you're not audibly grunting or going like this, but anytime that pressure changes within that intra-abdominal section, yes, that hernia will present itself. It's similar, and it's like a breach within the tissue.
Yeah. And can that be managed without surgery?
It can, to a point, sure.
Okay, if it gets big enough, surgery is always warranted.
Absolutely. But absolutely go get assessed. But there are functional hernias out there to where you don't need to necessarily go. I always say go get it looked at, and go talk about it with your physician. Absolutely. Because they need to be aware that it's there, so they can monitor it as well. But if you know how to activate correctly within your core, you can manage it very, very well, to a point.
Yeah. Okay.
Does that make sense?
Yeah. Oh yeah. Just like everything, to a point.
To a point.
Pelvic pain.
Pelvic pain.
Yeah. You see pregnant and postpartum women.
Yes.
Okay.
Absolutely.
Okay.
All through all stages. And that can arise really at any point. And can be caused from a number of different reasons. Yeah. Really. That muscle tension is obviously a big part of that pelvic pain when it arises. Our pelvic floor those muscles are very, very similar to any other muscle in our body, where it develops those trigger points and those painful spots. And it's a big, big source of pelvic pain. But other things such as, scar tissues from previous surgeries can cause, the restrictions in those muscles, and those muscles can't activate in their normal range. And so those pain patterns start to develop really at any point. And then you throw the trauma of delivery on top of it, and obviously the tears with episiotomies, things like that, where that comes into play. And then sometimes pelvic pain comes strictly from that. So it can come about really at any point,
and you can treat all those things.
Absolutely. Absolutely.
What about C-section scar massage? What's your thoughts on that?
I love scar tissue because it is just such a wicked, nasty spider web. But it layers itself, or it weaves itself through our many layers, and
particularly too if we've had multiple.
Absolutely. Absolutely. Scar tissue adhesion is such a huge part of what I see come in here. I would bet to say 95% of what comes through the door is
so interesting.
There is some sort of pelvic procedure that has been in the patient's history. So that scar tissue, it plays a big part in what's going on, whether it be incontinence or pain.
And do you think a lot of women know about it?
About the scar tissue part of it?
The manual therapy that you can do to help it.
No, I don't think so. I don't think a lot of doctors do. I just don't think it's been talked about very much or integrated enough to where we understand, or the general population understands how much scar tissue comes into play and what we can actually do to help realign that tissue and make things more free and able to move better and
more mobile.
Yeah, absolutely. I love scar tissue.
And you can do that starting at what point postpartum, and you can work on that all the way until you're
absolutely
80.
We can affect scars that are decades old, and it's just fascinating. Some of my patients that come in that are in their 80s, like you said, that have come through the years, and as they've gotten older have started to leak, they come in and we start to work on some of that scar tissue, because that scar tissue, it adheres right down to that bladder, and it can't function like it's supposed to. And
so interesting.
So from very, very early on, postpartum to decades old. It's just fascinating.
It is fascinating. Do you think that every postpartum woman should be assessed by a PT?
Yes, I do.
I do too.
Whether or not you have something that is big and blaring red flag problem that you're noticing, that's a huge change within your body, or you just want to make sure that you're going to be the healthiest possible with the core and the pelvic floor going into whether or not you choose to have more children, or just going through the next few decades of your life. I say yes, because you want to make sure that you can be taught the right tools to continue in that path, because it's just so important, so things don't arise down the road. So I say yes.
Okay. I like your answer. What have I not asked you about?
Oh goodness. Oh gosh, I could talk for hours. I do want to say, one thing I want to say, and we talk often in the realm of women and pelvic floor. We all have a pelvic floor.
Yeah, and so do men.
And women.
Yeah.
Both. When I say we all have a pelvic floor, it's just for years, well, when it has been talked about, it's been thought of in the realm of women, because we obviously have, the most changes that come about with pregnancy and childbirth. But I have so many patients that come in that are men. Yeah. And that, whether it be my cyclists, with nerve damage from the seat for so many years, or my truck drivers that bounce around, that pelvic pain, the incontinence, my guys that come in after prostate surgery, the same pain, the same incontinence, whether it be bowel or bladder, the same issues arise with men too. So I just, I always like to say, because it's always thought of in such a women's realm. Yeah. And it is, because we have, such major changes that happen. But pelvic floor, we all have a pelvic floor.
My husband would hate if he knew I was sharing this. He will never watch this though. But he got diagnosed with diastasis.
Did he really? Yes, men. Yes, I have a lot of men that come in.
My son, the one out here, he has diastasis too. Really? It's a very prominent coning. Really? Yeah. And so I said to my husband the other day, I said, "You realize you have pelvic floor dysfunction?" And he's like,
"Whatever."
What? You have a pelvic floor and it's dysfunctional right now.
I'm not a woman, right?
Yes. Yeah. So,
it's just, and I think that goes back to us as therapists, and the responsibility goes back to us as therapists, to get the word out and to let people know, not just the population, but doctors too, to let them know what success we see in the clinic, and how much, how many results we see.
That is something I do want to touch upon too. I have a lot of women say, well, my OBGYN never said anything. Well,
right.
But they're not going to assess the things that you do.
Not always. No, some of them do. Some of them do. More doctors are more and more getting involved and getting aware and getting on board with, hey, this really is a thing, to where the answer used to be, I don't know. I guess it just happened, to, hey, I think this may be what's going on. And when they do a vaginal exam, they notice, and they can start to notice kind of things that are changing, and things that have, maybe started to contribute to what you're noticing. Yeah. And so some OBGYNs do, and they will refer to therapy, and that's just fantastic. General practitioners, sometimes, a lot of times it's the patient bringing the idea that I've noticed into the office and say, hey, I've heard about this. Yeah. Do you think it would help? Or heard about this being the therapy, physical therapy. Do you think it would help? And they say, well, sure, let's try it. And then they come in and they'll have told me this story, but it just makes me aware that the doctor didn't know about it. So I think that, also goes back to us as a responsibility to go talk to them. And then when the patient sees results, to also go talk to their doctor and say, hey, look, this is, I went and this is what happened. And here's where we
tell
are.
More people.
Yeah, exactly. So doctors, we do get a lot of referrals, obviously, to urologists. A lot of them are on board. OBGYNs are getting more and more on board. So yes, they will start to assess, even OBGYNs internally, and even my urologist and that I work with in the urogyns, that they will assess internally and say, hey, I think this is what's going on. Why don't you go see a therapist? Okay. And see if that helps. So it is great. I'm just so thankful.
Yeah. Okay. Where is there anything else you want to add?
Oh gosh, maybe not on this interview.
Okay. Okay.
There's 1,000 more things.
Fair enough.
But I really just want to, if you notice anything, or you just want to be more aware of your body, because this is an area that we haven't had to think about for a really long time. Yeah. Until something goes wrong, and then we're like, what is this? I don't even know about this part. So, oh gosh, I encourage you, if you notice anything, please don't hesitate.
Yeah. Where can people find you?
I'm on the west side of Wichita at 119th and Central. I don't know. I think you have my information.
I do. I have lots of business cards. Do you have a website?
Not yet.
Okay, that's okay. That's okay. It's okay.
We're getting there.
Okay.
But yes. It's Summit Physical Therapy. Word of mouth is huge. Summit Physical Therapy, west side of Wichita. I have patients that don't think just because you're on the east side you can't drive over here. I hear that all the time. Oh, I live clear out east. Yeah. I have patients that come from 3 and 4 hours away, so you can come from
you can do it.
But really, I would love to see you. So, and let's see what we can do.
Yep. All right.
Okay.
Thank you for your time.
You're welcome. Thank you.
You're welcome. Yes.